Anybody, actually I'll just read the case. So I just did this case because we don't get a lot of neuro. So it's just like kind of approach to neuropathy. And I do a couple different types of neuropathy as well. Just so you guys get like, and this comes up all the time in JHAP and like, you know, no one ever knows what to order. So I figured I'd go over it. So this is a 72-year-old lady, this patient I saw in JHAP. She has history of hypertension, hyperlipidemia, AFib. She comes in with numbness on her feet. It's been going on for a while now, about 10 months. Started on the edge of her toes and since moved up to her mid-toes. It's symmetric on both sides. She doesn't have any other symptoms. She doesn't have any autonomic symptoms, no motor symptoms. She just has maybe a little bit of generalized fatigue. She had labs 3 months ago, which are shown here. So, oh, that's not working. So a little Chem 7 was normal. She got these LFTs with the AST of 18, ALT of 20, alk-phos of 80, total protein 8.5, albumin 2.4. Little family history, diabetes in her father, peripheral neuropathy in her father too, but he had diabetes. Social history, no drinking, so no drugs, no smoking, and then kind of that's it. So y'all can start asking questions about physical exam, further lab tests. What else do you want for this patient? What's up?
She always have a protein cap like that?
Wow, protein cap, what are you talking about? Tell me more.
It just caught my eye that there was a difference between the total protein and the albumin. In this case, it's about 5.1, but anything, I guess, greater than maybe like 4 catches my eyes, maybe suggestive of some other paraproteinemia.
Good. I thought I was going to be like a little subtle, put that in there, because I never look at the protein gap, but.
You are on that? No way.
Yeah, you guys are on it. Y'all got it. All right, yeah, so there's definitely a protein gap, but so I did try to give you all a little bit of a hint there of kind of where I'm going with this today. But great question. So never had like syphilis before. No recent screening for like HIV. No recent viral infections. Is something else you always want to ask with peripheral neuropathy. Does anyone know why? It's not like, say this was more ascending weakness with, yeah, Guillain-Barré. So yeah, it's always something to ask, especially because Guillain-Barré or AIDP could sometimes present mostly with a polyneuropathy with more sensation loss, but usually it's going to be that ascending flaccid paralysis with sensation loss. So those, we're kind of cluing on it. But no, great question. So perfect, yeah. So I mean, we're just kind of going through, typical workup. A1C, you get it, it's like 6.8 as well. Anything, other questions or any other labs that you kind of want for screen? Great, yeah. So what do you think about with the strict vegan thing? B12, yeah. So no alcohol use. No, she eats meat. She's cool with that. I don't know why I said it like that, but yeah. So no, not a vegan. But question, would you just get a B12 on her anyway? Would you? Yeah, you would. Yeah. For everyone with peripheral neuropathy needs a B12. That's a kind of a part of a learning point for this case. Her B12 was 250. So. No. So did you get a B12? This is actually now. These are now labs. I'm just going to go through now labs. Yes. Yeah, that's what I was trying to get the teaching point there. So intermediate range for B12 is 200. It's like, so less than 200, that's B12 deficiency. Intermediate range is 200, 300. So if you get this intermediate range, always do an MMA and a homocysteine, and they were both normal. So you'll see that in the hospital all the time, and it'll come back normal. So you kind of have to like remember that number, that 200 to 300. You have to remember that because that's going to be your reflexive MMA homocysteine. But those were normal as well. Yeah, usually I think it's high. Yeah, I'd have to go back over those, but yeah, I'm pretty sure usually it's high. Yeah, because it's like part of that pathway, and then I think the enzyme before it shuts down, so it shuts to MMA. Yeah, I'd have to look that up though. All right, so you get A1C, B12. Anything else that you might think about doing for these patients that's just part of your general workup, peripheral neuropathy? She got a little bit of generalized fatigue. Maybe I said she also has a little bit of, maybe I just added in this case, she had a little bit of constipation as well. You see maybe a little bit of hair loss on her outside of her, yeah, thyroid. So anytime someone has a peripheral neuropathy, and I think at this point I'll just kind of go into the workup for everybody. So the initial workup for everyone, so you got to think about first neoplastic causes. And I think we were going into that. So multiple myeloma can cause a peripheral neuropathy in a few different ways. One is that it can have anti-MAG, which is a paraneoplastic antibody to myelin. And then another one is actually called POEM syndrome too, which is polyneuropathy, organomegaly, endocrinopathy, M protein, and skin changes. So it's just a generalized syndrome that's thought to due to like increased VEGF production by those abnormal B cells, which basically gives a bunch of like autoimmune pathophysiology, like attacking the nerves with the polyneuropathy, attacking a lot of the endocrine glands like the thyroid or the adrenals, causing an endocrinopathy. As well as there are some skin changes, some kind of weird nodular rashes and things that you can see in these patients. So multiple myeloma can do it in a couple ways, as well as amyloidosis, obviously, which can be caused by AL amyloidosis or multiple myeloma. So everybody with a polyneuropathy, does anyone know how you kind of work these up? What would be your first tests? So S-PEP, UPEP, and one of the other ones that is kind of weird, but it's on MixApp, it's on UpToDate, is that everyone needs an ESR as well. I think it's just screening for any kind of inflammatory phenomenon, either autoimmune, infectious, or neoplastic. This was kind of crazy. Does anyone know why you get a UPEP? It's always like, oh, I gotta put the UPEP on, but like, why do we do the UPEP? So it's kind of wild. I had to look this up. So I'm kind of jumping around now, but when you have multiple myeloma, you have these, sorry, this is multiple myeloma over here. You have basically this monoclonal population of plasma cells, of plasma B cells that are secreting that same antibody over and over again. But when you have an antibody, you have two chains, right? You have the heavy chain here, and then you have the light chain on the outside. The light chain is so small that it's actually immediately filtered by the kidneys, and it goes into your urine. So if someone has a light chain multiple myeloma that's only secreting that light chain, is not secreting the heavy chain, then it's going to be immediately filtered from their blood, won't show up in the S-PEP, and will only show up on the UPEP. So that's the reason why we always send off a UPEP for these patients. So you do that. The next kind of category is deficiency. So, you know, a lot of different deficiencies can cause it. I always think of B1, thiamine deficiency can, dry beriberi, B3, B12. But for all of these patients, you have to check a B12. One of the other things is like, we always see our diabetics in the JHAP, and they're always on metformin, but metformin can actually cause a B12 deficiency. So, you know, I know like everyone's like, oh, they got a polyneuropathy, it's from their diabetes. But especially if you have someone with diabetes and they don't have signs and symptoms of like microvascular complications with their diabetes, they don't have CKD, they don't have proteinuria, if they don't have retinopathy, like you really still need to do this full workup because they're still at risk for B12. And like 10% of the population has diabetes too. So, I mean, just because you have diabetes doesn't mean you can't like actually develop like multiple myeloma or B12 deficiency. So this general workup is really for everybody. The last one, always check a med list. Does anyone know some meds that can cause a peripheral neuropathy? Yeah, I think yeah, chemos I think are like really the biggest ones. I think some antibiotics can do as well, but like when I think of it like cisplatin and carboplatin, like it's really the chemotherapies that I think of. And then lastly, always worried about endocrine, diabetes, thyroid disease, so as well as metabolic, which is like renal, liver. So all these patients, you really need to get a A1C, TSH, and then like a CMP. So that's kind of your general workup anytime you see someone with peripheral neuropathy. Like, so think about all those things, send them off. Yeah, that's kind of your primary care workup. And it's, if you look at it, it's mostly going to be, you know, toxins that are going to cause it. There are other causes as well that you don't always need to work up, but you should ask questions about, like heavy metal. Like you should ask them like heavy metal screening if they're at risk for that. You have to think about autoimmune disease. If they come in with, you know, other symptoms of lupus, like a malar rash, if they have a little bit of proteinuria, if they have any arthralgias, definitely like start thinking about autoimmune causes. But and if they have risk factors, always send off an HIV as well. But this is going to be your general workup. Anytime you have someone that has peripheral neuropathy, you're just going to automatically, reflexively do that. And the one that's kind of crazy is that all these patients are going to get S-PEP, UPEP, and ESR, just because it's not an uncommon cause. Someone getting peripheral neuropathy, especially in the absence of diabetes. All right. So that's kind of the workup. So we're just going to do it totally. I'm going to go back to that previous case in a little bit, but I want to kind of get you guys thinking about other causes of neuropathy as well. So we'll do another case real quick. So this is a 60-year-old lady, history of hypertension, hyperlipidemia, comes to the hospital with like 2 weeks of numbness on the top of her foot and wrist drop as well. Beginning worse rather quickly. She, I really didn't spell check look over my stuff. She also notes an ulcer on her leg, as well as some mild fevers, chills, shortness of breath, and some rust-colored sputum. And that's pretty much it. Does anyone have any other questions about physical exam, previous labs, just any thoughts? What are you guys thinking here? Actually, first off, what would you kind of call this pattern of neuropathy? So it's multiple nerves, most likely affected, in different areas. So I think putting a name to it probably is the first step. Yeah, mononeuritis multiplex, right? So this is really mononeuritis. I think people are putting stuff in the chat. Yep, Jesse, you got it. Mononeuritis multiplex. All right, so anyone have any ideas or further workup they would consider in this patient coming in with mononeuritis multiplex as well as this kind of nasty rash? Yeah. So what kind of things clue you in that this could be a vasculitis? So a lot of, you know, really most of them can cause it. I guess some of them cause it more commonly than others. Do you know what's the typical risk factor? So pyelonephritis, those that can happen by itself idiopathically, but there's also a certain infection that can put you at risk for it. Yeah. Sorry, Hep B. Yeah, so I get those confused as well. So Hep B, basically the way that infections cause vasculitis is that usually it's a type 3 hypersensitivity reaction. So you have really severe inflammatory response, usually to hepatitis B and hepatitis C, mostly because they can kind of change their surface glycoproteins. So the immune system has a really hard time getting rid of them because once they develop antibodies, it changes and then they have to develop more antibodies. So you basically get this response where you get increased antibody production. This binds to the antigens, then you get antigen deposition a lot of antigen antibody deposition, a lot of time in all of your vessels. And that then causes this vasculitis from subsequent complement, neutrophils, and inflammatory damage to your vessels. So Mononeuritis multiplex, so we got some causes. So you said ANCA first, so absolutely. You know, the primary vasculitis, does anyone want to name a couple of them? Either the old names or the new names? Yeah, GPA, Clusian. So maybe like something you might ask for this patient is they have rust-colored sputum, so we think, you know, there might be some kind of pulmonary renal syndrome, or at least a pulmonary syndrome going on, like a diffuse alveolar hemorrhage, or maybe they have some kind of inflammatory infiltrates there. But GPA, the big one is going to be like upper respiratory stuff. Like, do they have, is their nose, or do they have like epistaxis? Do you see a saddle nose deformity? They can also even get like tinnitus, can almost get like things that look like otitis media as well. So really that ENT stuff. The other ones are MPA, microscopic polyangiitis, EGPA, which is a pretty common, more common cause of Mononeuritis multiplex. And they'll have, anyone remember? History of, they'll have a, there's a, what's that? Yeah, they'll have a history of allergies. Yeah, so these patients will always have asthma. And the way that you can tell the difference is they'll have high EOs as well. And they'll also have, this is C-ANCA, and the rest of these are gonna have a positive P-ANCA. All right, so you send off the ANCAs, you send off the hepatitis B's.
Okay. Nick,
Yo,
for EGPA, is the severity of the asthma like related to development? Like more severe?
I think so. Don't quote me on that, but I'm pretty sure it's like, you know, a lot of times patients with like a pretty long history of like uncontrolled asthma, they get it. But honestly, I'm not totally positive about that. All right, say so you said hepatitis B you want us to check, but you absolutely want to check hepatitis C. So hepatitis C can, I think, cause polyarteritis nodosa, but it's uncommon. It usually causes a different form of vasculitis. Does anyone remember? Yeah, so cryoglobulinemic vasculitis. And anytime you want to check cryoglobulinemic vasculitis, you actually have to check cryoglobs as well. And always make sure that you check them while it's cold. It can't be warm, or else it'll mess up the sensitivity of the test. And then always check complements too. The other thing that you want to consider, I guess I'll just kind of go up to the workup of polyarteritis nodosa. So Mononeuritis multiplex. So when I think about Mononeuritis multiplex, this is really it's less about the nerves, and it's more actually about like the blood vessels that feed the nerves. So it's going to be mostly something attacking that blood vessel that's feeding the nerves. And it's usually going to be secondary to infarction of that blood vessel or infiltration from some sort of thing that's carried in the blood into the blood vessel, causing that Mononeuritis multiplex. So most of the time, Mononeuritis multiplex I think your first suspicion should be a vasculitis, something systemic going on that's kind of affecting your small to medium blood vessels, that's causing infarctions of nerves kind of around your body, which is going to give you this really asymmetric, mostly motor and sensory loss that really doesn't conform to like a defined distribution. It kind of can happen everywhere. They come in with the patient I saw once that had it, had like a foot drop, some sensation loss on their right toes, a foot drop on their left, and then like a wrist drop on their right. And it's just kind of this asymmetric like motor and sensory loss around the body. Every single person needs to get an EMG because you really do need to prove that this is going to be peripheral instead of like a central cause. You should have more suspicion for a peripheral cause of neuropathy instead of a central cause from the brain or spinal cord when it's like this, so asymmetric like this. But you do need to kind of rule those things out. So infarctions, we kind of talked about primary vasculitis. You want to send off the ANCAs. There's also like secondary vasculitis too. This can be really due to a lot of things. Like any of your autoimmune diseases can cause a secondary vasculitis. So lupus, RA, Sjogren's syndrome, if they get really, really severe, they can actually have autoimmune attack of the blood vessels itself. And these patients can have really presentations that makes you think about like your ANCA-induced vasculitis. They can come in with Peripheral, they can come in with Mononeuritis Multiplex. You know, you really will have to start considering that. And then also infections, we kind of went over that. Always want to send off HIV, Hep B, and Hep C. And then this is just some pictures kind of just going into the pathophysiology of Mononeuritis Multiplex. Like I said, here's a typical patient. I think this is microscopic polyangiitis, which here's the blood vessel here, and you can see this kind of inflammatory infiltrate around it. And really remember, it's kind of attack of your blood vessels. And one of the ones I didn't go into is that all these patients need to be worked up for Lyme disease as well. You think about Lyme disease really in the chronic state, you can actually have inflammation of your blood vessels. So here's a blood vessel there, here's some secondary inflammation, and then this was stained under fluorescence, and the patient actually ended up having Lyme. So another cause of Mononeuritis Multiplex is actually going to be Lyme disease, so you always want to send off. You'll start with ELISA and then go to Western blot if, you know, that's weird. The next one is going to be infiltration. So typical stuff that can cause this is, and I saw this one time in the hospital, I think, really your blood cancers, leukemia, lymphoma, can basically cause infiltration of those cells into your nerve. And then here actually is a staining of that. So here's a patient who had lymphoma infiltration. Here's their nerve here, and it's stained in blue. So you can actually see lymphoma infiltration into their nerve itself. And the secondary is, you know, amyloid. So anytime you got these patients, you really want to check S-PEP, U-PEP again. And then if you're really thinking that this Mononeuritis Multiplex, like you can't prove that it's a vasculitis, they don't have any infectious reasons for it. And especially if they have more of a subacute chronic presentation of Mononeuritis Multiplex, you really want to think about infiltration. And that's a time where you actually might get a nerve biopsy. So that's really the only way to prove it, is getting a sterile nerve biopsy for those patients. So this is just kind of your workup for Mononeuritis Multiplex. I know this is kind of a weird thing to go over, but I mean, you guys would never really get no one really ever kind of reviews how to work up your peripheral neuropathies, and how to work up polyneuropathy, how to work up Mononeuritis Multiplex. But just remember, if it's Mononeuritis Multiplex, think about something affecting the vasculature going into the nerves, causing that the systemic asymmetric peripheral neuropathy that doesn't really comply to like any of your nerve distributions. It just kind of can be anywhere. All right, so this patient ended up having you asked a little bit more. They ended up having some epistaxis. You got to CT of the lungs. They had these, almost looks like granulomatous, like caseating necrosis in there. C-ANCA comes back positive, and this patient was diagnosed with GPA, granulomatosis polyangiitis. All right, that is that case. All right, so we're going back to our case. So this is the peripheral neuropathy case, polyneuropathy, relating JHAP. So we get that workup. You know, she has the A1C of 6.8, so she's got diabetes, but her S-PEP shows an M spike of 1.7, and then that's immunohistologically stained, and it shows that it's IgM. So she got a decently high M spike. So the question is here, what is the diagnosis, or do we need more studies to kind of figure out what it is? So what do y'all think? What's that? Perfect. Can you let's go through that. Yeah. So perfect. You get a calcium. Calcium is within normal limits. So, yep, creatinine is normal. Anemia, so hemoglobin is like 13, so she's good, 13.5. And then, so yeah, no bone pain. No bone pain anywhere. So good. So, do we think we have the diagnosis yet? Or do we think we need more? What's on everyone's differential right now? MGUS, absolutely. Waldenstrom's.
Is this a situation where you'd say smoldering, multiple myeloma?
Smoldering. No, you're right. That's absolutely on the differential here. And multiple myeloma. Yeah. All right. Yeah. So that's kind of your differential. So this is mostly wanted to go over interpretation of S-PEPs because I think it's pretty confusing. So really when you're going through an S-PEP, all right, so what is it? So basically you put it on a gel electrophoresis, you know, it's negative, positive, and you kind of put the proteins on there, and these proteins starts moving, right? And they move depending mostly on the size of them. So albumin is big. So your first, basically your first spike that you're going to see when you're doing serum protein electrophoresis is going to be that albumin. So this albumin is right here. Then you mostly have a lot of like carrier proteins, maybe some acute phase reactions. And then really at the end is where you get all your immunoglobulins. Immunoglobulins are really small, so they travel pretty far in this gel electrophoresis, right? So they're kind of how to interpret this. So there's kind of two different things. So one, you can have a polyclonal gammopathy, not in this case, but does anyone know basic polyclonal gammopathy is that you don't have a spike, but you just have a kind of an increase in the amount of immunoglobulins you're producing. Does anyone know stuff that can cause this? Very general. It's like super good. Just you can give me super general causes. Yeah, and like chronic infections, autoimmune disease. Weirdly, the most common cause is cirrhosis. And I don't know, it said like it was correlated a lot with patients with autoimmune hepatitis, Hep B, Hep C. But like 60% of them are due to cirrhosis, usually due to like an infection. So anytime you see a polyclonal gammopathy, what that means is that they have normal plasma cells, right? And then they just have some sort of immune stimulus, and that immune stimulus is just making a ton of normal antibodies. And it's different B cells making a ton of normal antibodies, meaning that there's not going to be like a specific thin spike. They're just going to have a large amount of like a polyclonal expansion. So they're just going to have a large amount of protein in the gamma range, but it's not going to be a specific monoclonal protein. They basically just have proliferation of a lot of their B cells and a bunch of different proteins, immunoglobulins being made at the same time. So this is a little bit different than a monoclonal gammopathy. So a monoclonal gammopathy, this just means that in some way, shape, or form, there is a proliferation of a monoclonal plasma B cell. That monoclonal plasma B cell creates the same exact immunoglobulin, that's the same exact size, over and over and over again. It creates a ton of it. So when we think about a monoclonal gammopathy, we automatically go to multiple myeloma. We kind of go to, you automatically think that, which isn't wrong at all because that is the most common cause of a monoclonal gammopathy. But actually just general lymphomas, B-cell lymphomas can do it as well. So commonly CLL can do it, even like diffuse large B-cell lymphoma. If any of those cells are mature enough to actually make antibodies, they're going to make the same antibody over and over, and you're going to get a gamma spike. Weirdly, the rheumatoid factor in RA can do it as well. So even RA can give you a monoclonal gamma. Kind of weird. And then we have our different definitions. So I think we're getting to how do we prove something is MGUS, right? So one of the things is, does anyone know what the M protein has to be less than? Yes, so M protein, that M spike, has to be less than 3. And then you usually need something else as well to prove that it's MGUS and to prove that it's, you don't always need it, but this is a little bit advanced, but there's high risk MGUS and low risk MGUS. So low risk doesn't usually progress to like, it maybe like 1% a year. Like that it progresses like multiple myeloma or Waldenstrom's. And low risk means that M protein is less than 1.5. You always need to get a kappa lambda ratio. So normal kappa lambda. And then lastly, it has to be an IgG multiple myeloma. So an IgG MGUS. So if it has all of that, you can say it's low risk, and you actually might not need to do a bone marrow biopsy because it's low risk, it's unlikely to be multiple myeloma. But if someone has an M spike that is greater, so increased risk, someone has an M spike that's greater than 1.5, if they have an abnormal kappa lambda ratio, or if they have a non-IgG MGUS, you actually have to do a bone marrow biopsy. So this patient, we ended up sending for, was this ours? I made a bunch of this stuff up, but it was kind of based on our case where we saw, yeah. Remember her kappa lambda was really high, and we were like, oh, this is high risk MGUS. She got a bone marrow biopsy. And remember, it turned out to be, yeah. So in this case, I was loosely based off our case that we saw, but for her, so for an MGUS, does anyone know the cutoff? So we do a bone marrow biopsy. Does anyone know the cutoff of what percentage of plasma cells in the bone marrow it has to be less than for MGUS?
10.
Yes, less than 10%. All right, so back to our case. She has the crab workup, it's negative. She gets that. She has a kappa lambda ratio that's a little bit abnormal, but she gets a bone marrow biopsy and it's less than 10%. All right, so she's still got MGUS here. And then she doesn't return to clinic for a few years. So you're like, oh no, but you really should be monitoring these patients like every 6 months to 1 year. But she comes back in a couple years and her M protein is now 3.4. I won't belabor this one, but what is the diagnosis now? Or do you think you need, anyone think you need more studies? And what studies would you need?
So you have to, so I guess now the question is whether this is just by the M protein to meet criteria for smoldering myeloma.
Mm-hmm.
Now the question is, do you have full blown myeloma? So
Exactly.
we do the biopsy, check slow scan, look for plasmacytoma, check the crowd criteria.
That's perfect. Yeah, I didn't want to, we kind of went over that, so that's great. So the next thing is, right, so what is smoldering myeloma? So smoldering myeloma is you have either, an M protein greater than 3 or you have greater than 10% plasma cells. But like you were saying, you don't have any of the crab criteria. And one of the new things is that for the crab criteria, you have to check them for calcium, you have to check their creatinine, you have to check them for anemia. But for the bone pain, you actually have to check an MRI for all of these patients. And you actually are looking for their entire body to see if they have any lytic lesions. And if they have any lytic lesions, even if they don't have the other crab criteria, they are now in multiple myeloma. So bone scan is, what a bone scan is that you actually inject like radio labeled, something similar to hydroxyapatite, which is basically taken up by your osteoblasts and deposited in your bone. So you can see if the bone is undergoing if it's getting built up right now. The thing about this is something the boards may try to get you on. The thing about multiple myeloma, it's completely lytic and not elastic at all. So it only destroys bone, it doesn't build that bone back up. So a bone scan may be negative, which is why all these patients need an MRI. It's a very nuanced one, but you know, something they might ask you. So to prove smoldering myeloma, you need an MRI without lytic lesions. So multiple myeloma, how to make this diagnosis is that there's a couple different ways. So either you have greater than 60% of the bone marrow is plasma cells. A kappa lambda greater than 100 is another way to do it. And then any crab criteria. So that's kind of how you diagnose these patients with multiple myeloma. That's kind of the cutoff. So just kind of going through this, and this is really helpful too, because I mean, whenever you think about diagnosis is just really telling you when to treat or not to treat. So smoldering myeloma, you may not treat, but multiple myeloma, you do have to treat, and that's why making the distinction between smoldering myeloma and multiple myeloma is so important. All right. So she's diagnosed with smoldering myeloma. She is lost or actually, yeah, because you don't really know if it's smoldering myeloma or smoldering Waldenstrom's, but she's followed up once again, this time for a few years. She's presented to the hospital with blurred vision, dizziness, and tinnitus. Husband thinks she looks kind of clumsy when she walks. She also has some shortness of breath. Her chest x-ray shows pulmonary edema. S-PEP shows an IgA M protein component of 10 now, so it's really high now. Also, she does have some crab stuff, just kind of in the background too. She's got some lytic lesions now. And a little bit of hypercalcemia there too. Does anyone know what, this is a patient I saw, and it was in the 3 MICU, and then she came out to me afterwards up to Blue 1-2. But does anyone know what this is?
It sounds like
Yes, yeah, this is, what clues you in for hyperviscosity?
honestly, it's just the whole syndrome of like the blurred vision, dizziness, clumsiness, it's all.
And a high end protein. Yeah, so this is, yeah, it's,
Depending on some of the lost followers now coming in, and yeah, it's just.
and the confusing thing too sometimes for me was like, it was a patient with multiple myeloma and they came in hyperviscosity. I was like, I couldn't put it in my head because I was like, wait, that's Waldenstrom's. That's not multiple myeloma. But with multiple myeloma, it's like the difference between multiple myeloma and Waldenstrom's, like Waldenstrom has to be an IgM.
Yeah.
You actually weirdly can get an IgM multiple myeloma as well. But anything with a really, really high paraprotein can cause hyperviscosity. If you guys remember, IgM is a pentamer, so it's going to be super viscous. So you actually don't need a ton of IgM to cause hyperviscosity. That M protein just has to be greater than 4. For an IgG and an IgA, it has to be greater than 5 and greater than 7, just because of the size really of those paraproteins. So she was, I know, IgA, but she was at 10. So this was hyperviscosity. Does anyone know the treatment hyperviscosity, what you do right away? Yeah, so this patient was in the MICU, she got plasmapheresis. She had all the typical signs, the blurred vision, she had dizziness, tinnitus. We can tell if there's something neurological going on. And she even had heart failure. She probably had a little bit of diastolic dysfunction at baseline, but that hyperviscosity actually caused like lower cardiac output, and then she actually became in heart failure. So yeah, she actually improved almost right away with plasmapheresis. So I think this kind of last part, we have a couple minutes left. I just kind of go into the typical manifestations that you get from multiple myeloma. Like we think of the crab stuff, but there's actually other stuff that can happen as well. So if you remember multiple myeloma, you know, it's basically you have your normal plasma cells here, they undergo a mutation, and then you develop this monoclonal abnormal plasma cell creating a monoclonal antibodies. And this can cause a lot of different things, right? So we think about our crab phenomenon. Symptomatic management of this, does anyone know what you would do other than the general treatment of hypercalcemia? What medication is really helpful for this patient? Steroids, yes, as part of the treatment. Sorry, maybe it's a little bit of read my mind. It's like, so yeah, it's to read my mind. Routinely, these patients should be on bisphosphonates. If anyone has a lytic lesion, they should be on a bisphosphonate. So bisphosphonates are part of treatment for multiple myeloma with lytic lesions. For renal dysfunction, mostly just avoid nephrotoxic agents. Remember, the renal dysfunction is secondary to the deposition of those Bence-Jones proteins in the kidneys. But there's other reasons why these patients get it as well. They can get it from hypercalcemia, which causes afferent vasoconstriction. They can get it from the severe dehydration. They can get it from being sick a lot. These patients come in with sepsis a lot of times because they have humoral immunodeficiency, and that can cause recurrent AKIs. So it's not just the Bence-Jones, though that is the most likely reason why they get that renal toxicity. Anemia, treat symptomatically. Bone pain, once again, bisphosphonates. So that's kind of your symptomatic management. These patients are also, like I was just saying, at really high risk for infections because they have that abnormal production of antibodies. They have a decreased production of your normal antibodies. So they're actually at humoral immunodeficiency. So it used to be that these patients a lot of times would actually get IVIG, but mostly now they're just going to be on antimicrobial prophylaxis. So especially when you first start treating these patients, they may be on like Levaquin for bacterial prophylaxis. They may be on, if they're, part of the treatment is usually going to be dexamethasone. So they're going to be on PCP prophylaxis a lot of times. And this is super weird, but your proteasome inhibitor. So the typical treatment, I'm not gonna go over treatment too much, is like I remember it as Cyborg D. So it's usually an alkylating agent or immunomodulator. So cyclophosphamide, lenalidomide, combined with a proteasome inhibitor, which is usually bortezomib, combined with steroids. They get thrown around this triplet like there's a bunch of, if they do it in different ways, but I just remember with Cyborg D, that's one of the treatment is cyclophosphamide, bortezomib, and dexamethasone. But weirdly enough, your proteasome inhibitors actually cause HSV reactivation. So they actually need HSV prophylaxis if they're seropositive for HSV, and they're on a proteasome inhibitor, which is kind of crazy. So like Valsite or something like that. So that's infections. For neuropathy, about 10% of these patients will come in actually with spinal cord compression, basically from lytic lesion in their spine, and then a pathological fracture. So always be on the lookout. And any patient who has multiple myeloma and back pain, make sure you send them directly to the ED if they have any of those red flags, and just be really, really highly on the lookout for it. And then also peripheral neuropathy, which we kind of talked about. We talked about hyperviscosity. Treatment is going to be plasmapheresis. So how about this? This patient comes in here, they have this, anytime they Valsalva, they get this purple around their eyes. They also have hepatomegaly. They have like increased alk-Phos. Their tongue may be a little big. What kind of thing are you thinking about? It's a complication of multiple myeloma, macroglossia. What's that? Poems too, but this is amyloid. So that's the type of things that you might be thinking about when you think someone may develop amyloidosis. This is pinch purpura. It's actually due to abnormal protein fibril deposition in your skin. And then when these patients Valsalva, a lot of times they'll actually have rupture of the capillaries around their eyes. So it gives you these typical raccoon eyes. So amyloidosis is a typical outcome that these patients may develop. And things that might clue you in is hepatomegaly, nephrotic syndrome is another one as well. Macroglossia. Sometimes their shoulders they actually get like kind of joint enlargement, so their shoulders can get a little bit large. So think about those as well. And then lastly, something I didn't know is that you can actually have a coagulopathy. Basically from these abnormal antibodies start interfering with the coagulation cascade. So these patients are also more prone to bleed as well. So those are the things you just kind of got to think of. Oh, there it is. Those are kind of things you think of in just symptomatic management for multiple myeloma. When someone has it, they're much at higher risk for cord compression, higher risk for infections. And then, always have, when they're coming to the hospital, hyperviscosity amyloidosis under differential. I think that's all the time we got, Scott. But any questions about all this? All right. Thanks, y'all.